Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Treating Opioid Use Disorder in Correctional Settings. Medication for opioid use disorder reduces overdoses and opioid-related morbidity. And our presenter is Dr. Kelly Ramsey, Chief of Medical Services for New York State OASAS. She'll be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome our presenter.
Thanks so much, Dean. First, let's go over the learning objectives for today. Discuss briefly the epidemiology of the opioid use disorder and overdose epidemics. Discuss MOUD, or medication for opioid use disorder options, and the benefits of MOUD for persons with opioid use disorder. Discuss the pharmacology of MOUD and discuss myths and misconceptions about MOUD. Discuss MOUD in correctional settings and the benefits to inmates and correctional staff. Discuss legal precedent for MOUD in correctional settings and litigation legislation in New York State pertaining to MOUD in correctional settings. Discuss psychosocial strategies, treatment options, and strategies for engaging with persons on MOUD in correctional settings. So first, let's go over a little epidemiology. So here we have some pictures from the 2020 National Survey on Drug User Health, and it's looking at the intersection on the left-hand side between those with a mental health diagnosis and those with a substance use disorder diagnosis. So as you can see, there's a larger population of individuals who have either a single diagnosis of a substance use disorder without concomitant mental health diagnoses, as well as a population that has a mental health diagnosis that does not have concomitant substance use disorder. However, there is an overlap between those populations, approximately 17 million individuals who have both a substance use disorder and a mental health diagnosis. So it's important that we be duly competent in engaging individuals with both diagnoses. On the right-hand side is showing the source of opioid misuse. So again, there are many ways in which people may use opioids. They may use prescription opioids and misuse them. They may use heroin, and more commonly today, they may be using fentanyl and or fentanyl analogs, either intentionally or unintentionally. This data is from the National Survey on Drug User Health from 2019. They haven't done sub-analyses on the 2020 data yet. On the left-hand side is showing opioid use disorder, so the diagnosis of opioid use disorder, between the years 2016 and 2019. And they break this up into age groups: 12 to 17-year-olds, 18 to 25, 26 and older, and 12 and older. So we can see that there's a concentration of substance use, particularly in the 18 to 25-year-old age group, so something to be aware of in our younger adults. And on the right-hand side is looking at individuals with OUD who are receiving MOUD, so one of the 3 FDA-approved medications for the treatment of opioid use disorder. The good news is that the number of individuals receiving MOUD for their OUD is increasing over time. So that's a great signal that we see that, particularly with respect to the more efficacious medications for the treatment of opioid use disorder, particularly methadone and buprenorphine. However, those numbers aren't yet near where they need to be treating individuals with opioid use disorder and decreasing their risk for experiencing an overdose. This is looking at, on the left-hand side is 2020 data from the National Survey on Drug User Health, looking at the co-occurrence of substance use and a mental health diagnosis, either any mental health diagnosis or a serious mental health diagnosis, and how that interfaces with substance use. So as you can see, if you have a diagnosis of any mental health diagnosis or any serious mental health diagnosis, that is associated with increased substance use, regardless of which substance we're talking about. So you can see that that occurs across substances. And if you have a serious mental health diagnosis, there's more substance use than any mental health diagnosis. On the right-hand side is data from the 2019 National Survey on Drug User Health. And here we see that despite the fact that both mental health diagnoses and substance use disorder diagnoses are quite prevalent, we have a huge treatment gap. So with respect to any mental health diagnosis in the age group of those 18 and above, about 45% of those individuals will receive treatment for their mental health diagnosis at some point in their lifetime. However, 55% will not. The situation is even more dire when we look at substance use disorder diagnoses. Here it's looking at the population 12 and above with a substance use disorder diagnosis. Only about between 11 and 12% of those individuals will ever receive any treatment for their substance use disorder during their lifetime. About 89% will never receive any kind of treatment. Here is looking again at the epidemiology of those needing substance use disorder treatment and where they get their treatment. On the left-hand side is data from 2020, and that is looking at the percent needing substance use disorder treatment in the last year. So among the population 12 and above, it's almost 15%. Of those 12 to 17, a little over 6%, those 18 to 25, almost 25% of those individuals are in need of treatment. And in the 26 and older population, it's a little over 14%. On the right-hand side is looking at where they actually receive any treatment, if they do receive treatment. You can see that there's a tie between those that receive their only substance use disorder treatment from a self-help group. So that would be a group like AA or NA. And that's tied in frequency with going to an outpatient substance use disorder treatment facility. So again, good that people are receiving help when they need it. But again, we need to think about evidence-based medicine and where people receive their treatment, because they may be getting different messages depending on where they receive their treatment. Let's switch gears a little bit and look at the epidemiology of the overdose epidemic. This particular slide is looking at overdose deaths in late 2019, preceding the onset of the COVID-19 pandemic, and then during the early part of the pandemic. So it's covering overdose deaths between the time period of September 2019 and September 2020. So covering a full 6 months pre-pandemic and then the first 6 months of the pandemic. So unfortunately, what we saw is that in the latter part of 2019, overdose deaths began to rise again. They had gone down overall in 2018, so there were decreased overdose deaths in 2018 compared to 2017. However, unfortunately, even before the onset of the pandemic, overdose deaths started increasing again. So if you look at the last row in this chart, is the row I want you to pay particular attention to. You can see that deaths due to synthetic opioids, and that is referring to deaths due to fentanyl and its analogs, went up by 55% in that time period. However, almost as alarming is the number of deaths that went up due to stimulant use. And I think that this is under-recognized by the general public at large. So cocaine-related deaths went up 30% in that same time period, and deaths due to methamphetamine went up 46% in that time frame. Most of those deaths are due to fentanyl and its analogs being added unknowingly to the end user to the supply of cocaine and or methamphetamine that they are purchasing on the street. So this slide is looking at CDC provisional drug overdose deaths for 2021. So on the left-hand side, we're looking at substance use overdose deaths through October of 2021. So again, you can see that those deaths started increasing in the latter part of 2019. And if we look at specific substances that are driving those overdose deaths, the black line is due to opioids. Again, that would be referring to opioids overall. And then the brown line, which is just beneath the total overdose death line due to opioids, is due to synthetic opioids. This is excluding methadone and any other pharmaceutical synthetic opioid. This is referring specifically to illicitly manufactured fentanyl and its analogs. And then the gray line that is the next highest line is deaths due to psychostimulants. So that's again specifically referring to methamphetamine. Just below that is the line for cocaine. So while the stimulant overdose deaths are not keeping pace with the opioid overdose deaths overall, you can see that they are both risen significantly. So unfortunately, we hit a milestone that we've never hit before, and that was in the time period of October of 2020 until October of 2021. We had over 105,000 deaths due to overdose in the United States. About 2/3 of those deaths involve synthetic opioids, such as fentanyl and its analogs. This slide is looking specifically at overdose deaths in New York State, and it's looking across the years 2015 to 2021, looking at 12-month increments from October to October of each of those years. So as you can see, the number of deaths thus far that we have seen in 2021, that period is more significant with respect to overdose deaths than any prior year. And the vast majority, again, are related to opioids specifically. So the next section we're going to go through is looking at MOUD options and the benefits of MOUD for persons with OUD. So what is the evidence for MOUD? So before we get into the details of that, let's talk about social determinants of health for a moment. So social determinants of health have been in the news for quite a long time, and it's important to understand their role in health and health behaviors. So on the left-hand side is a depiction with an individual in the center and all the individual components that may make up that person's intersectionality with the system around them. So some of those components that play into well-being for that individual include education, food or food security, community and social context, their interactions with the healthcare system, economic stability, and the neighborhood and physical environment. On the right-hand side, if we drill down a little bit more significantly and look at what effect overall these factors have, we see them delineated in percentages. So socioeconomic factors such as education, job status, family and social support, income, and community safety, as well as the physical environment, comprise 50% of the social determinants of health that play into that person's well-being, and 50% can be traced back to the zip code that you grew up in. Another 30% of what fits into that person's well-being has to do with health behaviors, such as tobacco use, diet and exercise, alcohol use, and sexual activity. And only 20% of that person's well-being really has to do with access to healthcare and access to healthcare generally speaking, and depending on the quality of that care. So only 20% of the social determinants of health include moments of engagement in a healthcare environment. So next I want to talk about the vulnerabilities for developing substance use disorder. And obviously this is a simplification of a complex process, but just to give you a little bit of background on what constitute those vulnerabilities. So about 40 to 60% of the risk for developing a substance use disorder can be traced back to genetics. So in other words, a genetic predisposition to developing a substance use disorder. And what that means is that any substance use disorder in your family tree, regardless of what substance it was with, so whether it was an alcohol use disorder, a tobacco use disorder, a cocaine use disorder, confers a risk on that individual. If that individual also has concomitant mental health diagnoses, as we could see from the National Survey on Drug User Health slides, but that risk is particularly associated with certain mental health diagnoses, such as bipolar disorder, any anxiety diagnosis, so whether that's a panic disorder, PTSD, social anxiety, etc., major depression, ADHD, specific personality disorders such as borderline personality disorder or antisocial personality disorder, antisocial conduct disorder, which would be diagnosed in adolescence. And again, whether these are diagnosed and appropriately treated or undiagnosed or undertreated or inappropriately treated, that mental health diagnosis will confer additional risk onto that individual developing a substance use disorder. Very common among persons with a substance use disorder are a history of trauma and or abuse. Particularly, we're talking about pre-adolescent sexual trauma, particularly for females, and also for both males and females being either a victim of violence or a witness to violence. And often individuals may not want to talk about their trauma history when they first meet with you. They usually need an environment of trust and safety before they'll disclose that. But my clinical anecdotal experience has shown me that often males are less commonly see an abuse history in their own history, and often you have to ask specifically about have they been a victim of violence or a witness to violence to elicit that trauma history. Often individuals may have poor coping mechanisms, particularly for the trauma that they've experienced in the past, and maybe initially their substance use or substance experimentation will be around escapism. Impulsivity plays a role, and that's both biologically driven as well as being part of some of the mental health diagnoses. So to be more specific, when we talk about impulsivity, often substance use is initiated in the adolescent time period in our lives, and at that point, the prefrontal cortex or our frontal lobes are not fully developed. They do not fully develop until approximately the age of 25. And when we have full development of the prefrontal cortex or the frontal lobe, we are able to weigh consequences of our actions. We're able to delay reward for our actions. So in other words, we're not expecting an instantaneous reward with whatever actions that we have. So impulsivity plays a role in the initiation of substance use. So again, if that prefrontal cortex is not fully developed, people may not be able to weigh the consequences of their actions or be able to see a reward that's outlying. As well, diagnoses such as bipolar disorder and borderline personality disorder are associated with impulsivity. So there may be multiple factors that play into the impulsivity with initiation of substance use. Initially, again, people may be looking for just experimentation, sensation, novelty seeking. So that plays a key role in initiation. And then environmental triggers and sensory cues often are a trigger to use or to resume use. So think of these as sensory stimulation. So hearing a song that you associate with substance use, seeing a visual trigger that triggers you to resume use, or a smell that you associate with substance use. And also, what I noticed with my patient population is even when we put them on treatment, so say they started on treatment with buprenorphine for their opioid use disorder, often they didn't have the sort of socioeconomic mobility to change other aspects of their lives. So often they were still engaging with the same individuals who they had engaged in with when they were using, and often living in the same apartment or the same building or the same neighborhood where they previously actively used. So they're getting environmental triggers every day when they're just moving through their neighborhood. The more formal definition is a lack of homeostatic reward regulation or a reward deficiency. So when we start using substances, particularly at an early age when our prefrontal cortex or frontal lobe are not fully developed or matured, then we get an orientation towards pleasurable rewards or the priming of the brain by early substance use. So what happens is that individuals start using substances that are associated with euphoria, and to simplify it, they get a huge dopamine surge in their brain, which they cannot mimic with any sort of physiological pleasures that are not associated with substance use. So think of it like sex or eating chocolate or something that you normally derived pleasure from. Often you cannot receive that quantifiable reward that you would with substance use. And so you actually change both anatomical neural circuits. They are reoriented to seek pleasure, as well as you change the balance of neurotransmitters in the brain. So a normal dopamine surge associated with a normal physiological activity that you previously got pleasure from will no longer seem pleasurable in comparison to the dopamine surge or euphoria that you got associated with substance use. I want to talk for a moment about adverse childhood experiences, or ACEs, and their importance to our overall well-being and development. So, first of all, what is the definition of adverse childhood experience? So these are shown on the left-hand side. They include physical, emotional, and sexual abuse, physical and emotional neglect, and then household dysfunction, which includes things such as a mental health diagnosis in a parent or primary caregiver, having a parent or a primary caregiver incarcerated, having substance use in a parent or primary caregiver, seeing your mother or primary caregiver treated violently, and divorce or separation of your primary caregivers or your parents. So the more ACEs that a child experiences, the more of a potential impact that can have on their well-being. So what does that look like? So on the right-hand side, we have a pyramid starting at the bottom. First, if you add in generational or historical trauma that individual's parents or family may have experienced, and then you add on social conditions or a local context, so the neighborhood that they live in, all those other factors that played into the previous slide that I had showing how an early environment impacts a child's or an individual's development. You add on some of these adverse childhood experiences. Those factors lead to disrupted neurodevelopment in that individual, which can lead to social, emotional, and cognitive impairment, which can lead them to adopt a health risk behavior, or what we might label, quote, risky behaviors, unquote, to cope with some of the factors that they're experiencing in response to these other building blocks. That could lead to potentially disease, disability, and social problems or other problems due to their adoption of that risky behavior, and potentially that could lead to an early death. So I want to switch gears now and talk a little bit about stigma in healthcare settings. So what is stigma, first of all? So stigma includes attitudes, beliefs, behaviors, and structures at multiple levels. So this could be the individual level, a group level, an organizational level, or a system level. And this can lead to prejudice or discrimination against people with mental health diagnoses, substance use disorders, and I would add certain physical health conditions such as HIV and hepatitis C. So what stigma does is perpetuate stereotypes and assigns labels such as dangerous, non-compliant, or incapable of managing treatment, dirty, at fault, etc. So these are non-neutral terms. These are derogatory terms. This can be internalized to make people feel that they are not deserving of being treated with dignity and respect. So that is called internalized stigma. This can lead to fear and shame and isolation and feeling unwelcome, judged, or unworthy of seeking or receiving services. So stigma limits a person's ability or desire to access services, and ultimately, stigma contributes to suboptimal and sometimes traumatic healthcare experiences and health outcomes. There's also a relationship between stigma and trauma. So we should realize that most people have experienced trauma in one form or another in their lives. This could be personal trauma that they experienced or generational and historical trauma. People with a substance use disorder are more likely to have experienced trauma, including trauma in healthcare settings, substance use disorder treatment settings, or even, for example, in a pharmacy setting when going to pick up their prescription for buprenorphine. We must recognize how trauma affects people. It impacts physical health, neurobiology, and cognitive, social, and emotional functioning, as we demonstrated on the prior slide about ACEs. Perceived, quote, high-risk behaviors, unquote, can be a way of coping with trauma. So we must consider how past histories of trauma, violence, and layers of disadvantage and stigma play into how an individual may engage with providers or not engage with providers and pharmacists, for example. We should be committed to not repeating trauma or creating more trauma. In other words, we should commit to not re-traumatizing the individual we are trying to engage in care. So what we say and how we say it matters. Bad language perpetuates stigma. So words do indeed perpetuate stigma, especially when they imply fault or immorality. Stigmatizing language, either verbally or in our medical records or at the point of care, not only affects how patients feel, but it can also affect the care that they receive for years to come by perpetuating bias among other providers or pharmacists by your chart records or your logs, for instance. It's important to use person-centered language, so a person or a patient with a substance use disorder, as opposed to labeling and defining the person by that substance use disorder diagnosis. We should use language that reflects an accurate science-based understanding of substance use disorder as a complex medical condition and use clinically accurate, non-stigmatizing terminology. We should avoid moral judgments, assumptions, or subjective language. So let's talk about some best practice in avoiding stigmatizing language and in using strength-based language for our documentation. On the left-hand side is just one example of one of many available charts that go through language that's not appropriate to use and language that's better to use and why we're making that distinction. So just to give a very small example. So if we use a word like addict, abuser, or junkie, what we're doing is that we are defining that person by their substance use. So they've become limited to just their substance use instead of being a person or a human being who has an attribute, whether that attribute is using heroin or having a cocaine use disorder, et cetera. In the terminology of clean and dirty, we are clearly using non-objective language to define either a time when someone is using or not using, defining their toxicology results, etc. So when we use that terminology of clean and dirty, which we don't use to describe any other individual with any other health condition, we are assigning positive attributes to clean and negative attributes to dirty. So again, these are not factually accurate, and more importantly, we wouldn't describe anybody else with that type of language, which is clearly stigmatizing. So if, for example, we're talking about toxicology results, we could use terms like consistent with patient's report or not consistent with patient's report, or appropriate or inappropriate, or expected or unexpected. If we're talking about a time when someone is actively using, we can say that they're currently actively using heroin. Or if they're not using drugs currently, then we can just say the person is not using substances. So again, if we're talking about a person, we would not use those terms either. So a person who is in recovery, a person who is not currently in recovery. We don't need to use those terms ever when describing individuals or their behaviors. In looking at deficits-based language versus strength-based language, I'm not going to go into each example here, but I'm just going to focus on a couple of examples. So probably my least favorite term is when people who use substances are labeled manipulative. So really, when a person pushes our buttons or we get our buttons pushed by a person's behavior, we need to step back and think, what is it about that that's bothering me so much? So typically patients who are described as manipulative are self-advocating for something that they either have or they want to maintain, or that they don't have and they would like to have. And so we're really reacting to that behavior. We may disagree with what they're advocating for themselves for, but another way of thinking about it is looking at it clearly from the patient's point of view, and really it's about self-advocacy. So how about we use a term like resourceful instead of manipulative? It is conveying the same idea, but in a positive light. Another thing that we might say, for example, is the term unfit parent is often applied to pregnant and parenting persons. Again, that somehow their substance use confers their inability to parent. So rather than using a very stigmatizing term like that, how about we use a term like a person who is experiencing barriers to successful parenting, and then offer them the support that they need. So to kind of sum this up into the social determinants and social needs, unfortunately, often we are engaging with individuals downstream. So we're providing clinical care and medical interventions without considering the context that preceded their interaction with us. So we need to remember about the impacts that happen in other parts of the stream. So for example, community impact upstream. So that's trying to improve conditions in the communities where our patients live. What are some tactics that we can apply there? Laws, policies, and regulations that create community conditions that support the health for all people. What about the individual impacts? So these would be midstream activities. We can address individual social needs. So what does this mean? It could be patient screening questions about social factors like housing and food access, using data to inform our care and provide referrals. And this involves social workers, community health workers, care managers, community-based organizations, providing direct support and assistance to meet patients' social needs. So even though we're primarily interacting with people downstream, it's important to remember the other factors that occur mid and upstream and try to effect positive change in those realms as well. So what are some evidence-based strategies for preventing opioid overdoses? So there are quite a few strategies listed here. So targeted naloxone distribution. So again, looking at where overdoses happen and making sure that naloxone is in the hands of individuals who are at risk of experiencing or witnessing an overdose. Medications for opioid use disorder, which we'll go into in more detail. Academic detailing, eliminating prior authorization requirements for MOUD. So there has been a uniform MOUD formulary in New York State for Medicaid. That is one way to eliminate prior authorization. So in other words, any medication for opioid use disorder that you prescribe to an individual with Medicaid in New York State no longer needs a prior authorization. Screening for fentanyl in routine clinical toxicology testing. 911 Good Samaritan laws, so protection for those who are experiencing an overdose or calling 911 in the context of an overdose. Naloxone distribution in treatment centers and criminal justice settings. So recognizing that overdose happens even in unexpected places like treatment centers and criminal justice settings, and making sure that naloxone is available there as well. So MOUD in criminal justice settings and upon release, which will be the focus of the bulk of the rest of this talk. Initiating buprenorphine-based MOUD in emergency departments. So when people come in post-overdose or people come in acute withdrawal, treating them and linking them to care. And syringe service programs, and I would add overdose prevention centers now that we have 2 open in New York City. So let's go through what is the evidence for the use of MOUD or medications for opioid use disorder. So this is a very old clinical trial that was published in 2003, and this was the very early evidence that showed that maintenance on buprenorphine for opioid use disorder led to high rates of retention in treatment, as well as high abstinence or non-use of opioids verified by urine toxicology. So what they found was that in a group who was detoxified, so in other words, treated very briefly with medications just during the acute opioid withdrawal period, who were then rapidly tapered off and not maintained on medication, that none were retained in treatment, and 20% of that group, so 1 in 5 individuals, died due to their opioid use disorder. So they died due to overdose. In contrast, for those that were maintained on buprenorphine, approximately 75% were retained in treatment over 1 year, and 75% of the toxicologies were negative for opioids. This is a study that came out in 2014, again, looking at tapering versus maintaining. And as you can see here, what they showed is that if you maintain people on treatment, then they stay retained in care. However, if you taper individuals off of medication, they are not retained in care. So this was a study that was done in Baltimore, Maryland, over a long period of time between 1995 and 2009. And what this was looking at was what impact does medication have on overdoses? So what they found is if you put individuals on methadone or buprenorphine, over time, you got a huge decrease in the number of overdose deaths. So heroin overdose deaths decreased by 79% over the course of this study in individuals who were put on either methadone or buprenorphine. This was a meta-analysis that was looking at, again, individuals on either methadone or buprenorphine, and then looking at in-treatment mortality rate versus not in-treatment mortality rate. So they looked at both all-cause mortality and mortality due to overdose. They particularly saw a huge impact when people were on methadone versus not on methadone. It was significant in both groups, but I'm highlighting here the data with respect to methadone. What they found is that there was a 3 times higher mortality rate for individuals who were not in methadone or opioid treatment programs, so on methadone and opioid treatment programs, compared to those that were on treatment and opioid treatment programs on methadone, and a 5 times higher overdose mortality rate for those that, again, were lost to care from being in an OTP. This is looking at the fact that detox in and of itself is not effective for opioid use disorder. So what they found is that 83% of individuals resumed use at 30 days. So compared to a first attempt at detoxification, a second attempt was 32% less likely to be successful. A third attempt was 44% less likely to be successful. A fourth attempt was 47% less likely to be successful. And a fifth attempt was 59% less likely to be successful. So in other words, the key to success is maintenance on MOUD, not a brief detoxification period and then a rapid taper. So this is a very wordy slide, but I'm just going to go over the key highlights here. So this was looking at the evidence again for MOUD, and it was looking at comparative effectiveness of different treatment pathways for opioid use disorder. So it looked at outpatient counseling, intensive behavioral health, inpatient detoxification or residential services, buprenorphine or methadone, and naltrexone. And the bottom line here is that methadone and buprenorphine were associated with reduced overdose and opioid-related morbidity compared to no treatment. Naltrexone, inpatient treatment, and intensive behavioral interventions for opioid use disorder were not associated with reduced overdoses and opioid-related morbidity. This specifically was looking at MOUD plus access to harm reduction services. So achieving a 40% reduction in opioid overdose mortality required increasing capacity for treating with medications for opioid use disorder, improving retention on those medications, and increased naloxone distribution. So methadone and buprenorphine remain the gold standard of care for opioid use disorder. Studies indicate that persons on MOUD are more than twice as likely to remain opioid-free. A meta-analysis of over 300 published research studies confirmed that MOUD, methadone, and buprenorphine to be clinically effective. And from the Legal Action Center in 2011, scientific research has firmly established that the treatment of opioid use disorder with medication reduces opioid use disorder and related criminal activity more effectively and at far less cost than incarceration. So when we think about using MOUD, how long should persons remain on MOUD? So that is really based on that individual. So my short answer is long enough, but what do I mean by that? What I mean is that as long as the patient receives benefit from taking the medication, the patient should stay on the medication. So the answer is different for every patient, but return to use and fatal overdose rates are higher for shorter courses of treatment and for no treatment. So the way that I think about it is, as a minimum, a patient should remain on MOUD for 12 to 6 months. But in reality, MOUD is often much longer and for many individuals may be a chronic medication. There's only been one study that I've seen thus far that looked at average duration on treatment. So specifically with buprenorphine, that study showed that the average duration of treatment was 8 to 9 years. But a way to reframe it for ourselves to think about is that opioid use disorder is a chronic disease, and like other chronic medical conditions or diseases, may require medication chronically. So think long-term versus lifetime, but not short-term. So like a person with diabetes needing insulin for life to manage their diabetes, there may be many individuals who need to remain on either buprenorphine or methadone chronically. The study on the right-hand side, I'm going to just cut to the conclusion, is that a considerable number of patients enrolled in medication for addiction treatment have experienced overdose. Our study highlights that there are identifiable factors with a patient's overdose status that may represent areas for intervention. In particular, longer duration in medication for addiction treatment is associated with a decreased risk of overdose. So now let's look at some of the myths and misconceptions regarding MOUD and at the pharmacology of MOUD. So first, what are the goals for MOUD? So the number one goal is to decrease the risk for fatal and non-fatal overdoses. Also importantly, MOUD eliminates opioid withdrawal syndrome when we're talking about methadone and buprenorphine. It decreases opioid cravings, which often are a precursor to resumption of use. They increase patient functionality. They help to normalize brain anatomy and physiology, which have changed due to use. And they also decrease transmission and acquisition of viral infections such as hepatitis B, hepatitis C, and HIV, and infection-related complications such as abscesses, cellulitis, and endocarditis. There are 3 FDA-approved medication options for opioid use disorder. They are methadone, which is a full agonist. This must be dispensed for an OTP for the diagnosis of opioid use disorder. And as I've mentioned, methadone is associated with decreased mortality. Buprenorphine, which is an opioid partial agonist, it is a Schedule III drug. So in other words, it can be written with refills by a provider. It does require a DEA X waiver to prescribe it. However, in the last year or so, they have eliminated the requirement for an educational component if a provider's intention is to prescribe to fewer than 30 individuals at one time. If a provider intends to prescribe to greater than 30 individuals at any given time, then there still is a required educational component. Buprenorphine is also associated with decreased mortality. Naltrexone is an opioid antagonist. It is not a controlled substance. Notably, it is not associated with decreased mortality. So now let's talk about the mechanism of action and mu opioid receptor availability and activity. So looking on the left-hand side is a depiction of, simplistically, of the differences between full agonists, partial agonists, and antagonists. So first, let's talk about full agonists. So those are represented by the red line. So full agonists mean that they fully activate the mu opioid receptor. So this would include pretty much any opioid that you can think of that you can misuse, such as heroin or oxycodone, or hydrocodone or hydromorphone, etc. Fentanyl. It also includes methadone as the treatment for opioid use disorder. So what does a full agonist do? By fully activating that mu opioid receptor, and you can see by the curve that it doesn't really level off. So what happens is that you achieve more and more euphoria the more you use, until if you take enough of that full agonist, you will go into respiratory depression and into an overdose, which would be fatal if not reversed by naloxone. In contrast, buprenorphine represents a partial agonist. So what does that mean? What it means is that it does not have the same kind of no holds barred effect that a full agonist does. So by having a ceiling effect, that makes it a safer opioid. So in other words, the risk for overdose is really going to be quite limited in people who are opioid tolerant. So if somebody already has an opioid use disorder, they are not going to feel euphoric effects. So if they already have tolerance to opioids, they're not going to feel euphoric effects due to buprenorphine. They're also not going to be at risk for respiratory depression as they would be with a full agonist opioid, or particularly with a full agonist opioid coupled with a benzodiazepine, for instance. So what this means is that buprenorphine is a safer opioid than any other opioid because of these principles that are part of the pharmacology of it being a partial agonist. So it does have a greater safety profile than the other full agonist opioids. An antagonist, which represents naltrexone as a treatment for opioid use disorder, but it also represents naloxone as the antidote to overdose, has no activation at the mu opioid receptor. However, not only does it block exogenous opioids that a person might use, but it also blocks endogenous opioids. So it can lead to increased dysphoria because, again, you're getting a blockage of endogenous opioids are similar to dopamine and that they're associated with things that are pleasurable. So not only are you having a lower dopamine level when you're using an antagonist because you're not getting any activation of the mu opioid receptor, but you're also blocking endogenous opioids. So how that particular medication or substance interacts with the receptor is depicted on the right-hand side, showing full activation, partial activation, and no activation. So here is illustrating the concept that I showed in the last slide of the ceiling effect associated with buprenorphine. So it's a very low overdose risk. So on the left-hand side, you see buprenorphine pitted against pretty much all other, not every other full agonist opioid, but many other full agonist opioids. And you can see that the safety profile for buprenorphine is much, much better than for the other substances because your relative risk of overdose is almost non-existent. On the right-hand side is looking at the interaction of benzodiazepine and Z drugs, which are drugs that are used most typically for sleep. So that would be a drug like Zolpidem or name brand Ambien. So a lot of providers are concerned about prescribing buprenorphine if somebody is either prescribed benzodiazepines or they're using benzodiazepines illicitly. And really, what I think people should understand is that that overdose risk is actually partially mitigated by being on buprenorphine, because buprenorphine, again, is going to be a safer option for somebody who would otherwise be using full agonist opioids. So the conclusion here was increased risk of non-fatal drug-related poisoning is associated with benzodiazepine or Z drug treatment in patients with opioid use disorder, but this risk is partially mitigated by buprenorphine treatment. Dose reduction of benzodiazepines or Z drugs while maintaining buprenorphine treatment may provide the advantage of lowering the drug-related poisoning risk. So in other words, people who may encounter an individual who is misusing opioids and benzodiazepines or Z drugs, it would benefit the individual to prescribe buprenorphine to them because it will decrease their risk for overdose compared to heroin or fentanyl or any other full agonist opioid they may be using. Another thing I wanted to point out is that OASAS did put out with the New York State Department of Health in 2019 a best practice document on prescribing buprenorphine in a low threshold manner. So these are some of the key points that were made in that document. Prescribers should ensure continued access to buprenorphine even in the absence of counseling. Prescribers should ensure immediate and continued access to buprenorphine for patients who are at the time may be unwilling or unable to participate in counseling or other formal psychosocial services or supports. Prescribers should not discharge patients solely based on the use of prescribed or unprescribed substances, including but not limited to cannabis and benzodiazepines. Prescribers should ensure continued access to buprenorphine even in the presence of other substance use, and prescribers should strive to minimize diversion and avoid allowing concerns about diversion to prevent them from treating opioid use disorder. So again, the key is access to medication, access to naloxone, and engagement in care. What we see is that overdose risk increases when someone has no engagement in care at all. So this is a lengthy definition, which I'm not going to read through, but this is SAMHSA's definition of person-centered care. And what I think are the most important points to make is that a person-centered care process is a collaborative process where the individual who is receiving the care does participate in the development of their own treatment goals and how they define their progress in their engagement with you. So it's really important that if we're doing effective person-centered care planning, that would strengthen the voice of the individual and it will build their own self-efficacy and their own resilience, and that will foster recovery. So harm reduction is a strategy that's employed in person-centered care. So let's briefly go through some myths and misconceptions about MOUD. So myth number one, MOUD just trades one addiction for another. So let's go through the facts. So both buprenorphine and methadone do cause physical dependence to an opioid. So in other words, if people were not able to access their methadone or buprenorphine, they would go into opioid withdrawal. So what it's important to understand is that physical dependence is not equal to addiction or a use disorder. So OUD is characterized by a compulsion to use opioids with associated behaviors that can lead to dysfunction in the life of a person who's using drugs. Buprenorphine and methadone allow people to stabilize their lives. So again, their mu opioid receptors are occupied by these medications, and that keeps opioid withdrawal symptoms at bay and controls opioid cravings that allow a person to regain functionality in his or her life. Myth number 2, MOUD is only for the short term. So let's go over the facts here. So research, some of which I've already demonstrated, has consistently shown that people maintained on MOUD for longer durations have better long-term outcomes than those who are taken off MOUD. There is no evidence to support benefits from stopping MOUD. Next myth, my patient's condition is not severe enough to require MOUD. Fact, given the lethality of the current opioid epidemic, and specifically fentanyl and fentanyl analogs, preventing unintentional opioid overdose among people who use opioids is a key goal of MOUD. MOUD is now recommended for persons who use opioids, including adolescents and all pregnant persons, even if they do not meet DSM-5 criteria for opioid use disorder. The 3 MOUD options allow tailoring of treatment to meet each person's needs. Myth, MOUD increases the risk of overdose in patients. Fact, research has shown clearly that both methadone and buprenorphine use are associated with decreased risk for mortality due to opioid overdose. Occupancy of the mu opioid receptors by either methadone or buprenorphine protects a person who uses drugs from an unintentional overdose if he or she returns to use with opioids. Myth, providing MOUD will only disrupt and hinder a patient's recovery process. Fact, MOUD has been shown to assist people who use drugs in recovery by improving their lives, their level of functioning, and their ability to handle stress. Most importantly, MOUD reduces mortality while people who use drugs begin their recovery process. People who use drugs are often more open to other supports such as counseling, peers, etc., for their recovery once stable on MOUD. Myth, there isn't any proof that MOUD is better than abstinence. Fact, MOUD is evidence-based and is the recommended course of treatment for opioid use disorder. So many professional organizations such as AAAP, the AMA, NIDA, SAMHSA, the NIAAA, CDC, and WHO emphasize MOUD as first-line treatment for opioid use disorder. Myth, most insurance plans don't cover MOUD. Fact, this is no longer true. Most Medicaid, Medicare, and private insurance plans cover MOUD, and often without a prior authorization. So now let's look at MOUD in correctional settings and the benefits to inmates and correctional staff. So what evidence do we have of that? So this is a bit of a busy slide, but this is looking at mortality post-incarceration. So what it's showing is that basically that your risk of death, particularly shortly after release from an incarcerated setting, goes up exponentially. And this was shown across settings. So particularly in the immediate release period, so 1 to 2 weeks after release from prison, that regardless of where we were looking at this in the UK, in Australia, in the US, the risk for death due to overdose rose exponentially shortly after release. So why should we use MOUD within the correctional setting? What evidence do we have to do that? So corrections-based MOUD programs have resulted in healthcare cost savings, including reduced crime and recidivism. Costs for incarcerated individuals receiving MOUD post-release were half the cost for inmates who did not receive MOUD post-release. Increased knowledge of substance use disorder among correctional officers when MOUD is in the correctional setting, and decreased rates of overdose in the community post-release. So providing MOUD during incarceration leads to important benefits post-incarceration: reduced illicit opioid use, reduced criminal behavior, reduced mortality and overdose risk, reduced HIV and Hep C risk behaviors, so specifically reduced injection drug use, reduced rates of recidivism when treatment is continued in the community after the correctional setting, reduced arrest, and reduced probation revocations and reincarcerations. So this slide is looking at reduction in mortality post incarceration. So it's looking at specifically overdose-related mortality and all-cause mortality. And what they did was they looked at a population who was maintained on opioid therapy. So that's specifically referring to methadone or buprenorphine after incarceration. So what they found was that there was a 75% decrease in all-cause mortality and an 85% decrease in overdose-related mortality among those that were maintained on opioid agonist therapy with either buprenorphine or methadone after incarceration. So the other thing that we need to remember is that, criminal justice involvement among those that are using opioids is quite widespread. So if we look at an individual with no opioid use, then their criminal justice involvement is about 15%. If we look at individuals with prescription opioid use, then their criminal justice involvement jumps to a little over 20%. If we look at prescription opioid misuse, jumps to a little over 30%. If we look at an opioid use disorder due to prescription misuse, that jumps to over 50% are criminal justice involved. And if we look at a person who is using heroin, then that criminal justice involvement jumps up to about 75%. So another way to look at it is looking at what happens when we don't have MOUD in the criminal justice setting. So first of all, let's look at what some of the stats are in the last few years around access to MOUD in correctional settings. So on the left-hand side is looking at that availability of MOUD in the criminal justice system. So let's look at its availability in jails and prisons. So 30 out of 5,100 prisons or jails in the US offered methadone or buprenorphine in 2017. Fortunately, we are going in the right direction with respect to this. 14 states offered methadone or buprenorphine maintenance for jail or prison inmates in 2018. What about in drug courts? 80% of drug courts in a 2018 study, participants with OUD were 80% less likely to graduate from drug court. 50%, approximately 50% of drug courts required participants to discontinue methadone or buprenorphine within 30 days in a 2017 study. So again, not evidence-based. Less than 50% of drug court participants with OUD received MOUD in a 2018 study. What about those that are involved in reentry or community corrections? 45% of state and federal prisons in the US referred inmates for methadone maintenance or to an opioid treatment program after release in 2009. 29% of state and federal prisons in the US provided referrals for community buprenorphine providers in 2009. Without MOUD, there was a 10 to 40% higher risk of death from overdose within 2 weeks of release from prison in a 2018 study, and less than 5% of persons with OUD referred to treatment in 2014 by probation, parole, or court authorities received methadone or buprenorphine, compared to 41% referred by non-criminal justice sources. So when we think about those approaches that don't allow MOUD, what are the outcomes? We've talked about the high overdose rates among those individuals who do not have access to MOUD, but nearly 50% are rearrested in the first year after release, and over 75% return to use after they are released from custody. So let's go through some more evidence. 65% of the US prison population meets a DSM-5 criteria for substance use disorder. An additional 20% don't meet DSM-5 criteria for substance use disorder, but have substance involvement at the time of their crime or were arrested for a substance-related offense. Less than 1% of justice-involved individuals in need of opioid treatment were given the option of MOUD. On the right-hand side, and this has DSM-4 language. So in the DSM-4, they didn't have the term substance use disorder or opioid use disorder. They used the term substance abuse and substance dependence. But you can see in looking at the general population of adults versus the sentence jail population and the state prisoner population, you can see, and again, remember, substance use disorder as a diagnosis would cover both those definitions, former definitions of abuse and dependence. So you can see that those that are involved in jail and or prison have very high rates of substance use disorder in comparison to the adult general population. So why use MOUD, naloxone, overdose education, and linkage to care in correctional settings? And what would the possible benefits be for correctional staff? So there's less contraband coming into jails and prisons and improved morale for staff. There's a calmer and quieter jail or prison environment, an increased overall health of incarcerated individuals, reduced overdose deaths in the incarcerated community, increased job satisfaction among correctional officers, fewer safety and violence issues, and reduced recidivism rates. What are the strategies to address diversion concerns in correctional settings? So first, what are some of the basic strategies to employ to avoid diversion? Alter the administration route from sublingual tablets or films to buccal films. So these are absorbed in the cheeks, so easier to visualize instead of under the tongue. Or consider, where it's an option, extended release formulations, so such as name brand Sublocade. Improve dose monitoring and administer medication and house individuals on MOUD separately. So you don't create an environment where some are on the medication and some are not on the medication. Identify and address root causes. So are individuals being underdosed? Are individuals being bullied, pressured, or threatened for their medication? And expand screening and access to MOUD to reduce demand for diverted medications. So what are some of the legal considerations for utilizing MOUD in correctional settings? So there are a couple. So first is the Eighth Amendment to the Constitution guarantees the right to health care for detainees. So medical care, quote, at a level reasonably commensurate with modern medical science and prudent professional standards, unquote, is expected. So, i.e., not providing MOUD for the treatment of OUD is not commensurate with the medical standard of care. Failure to address opioid use disorder can be interpreted as, quote, deliberate indifference, unquote, or cruel and unusual punishment to a serious medical need. It's also a potential violation of the Americans with Disabilities Act, or the ADA, which prohibits state and local governments from discrimination based on disability, and OUD and other substance use disorders are generally considered a disability. The ADA is violated when a person has a disability and is denied the public entity's services, programs, or activities because of their disability. And what are some medical considerations for using MOUD in the correctional setting? OUD is a chronic, treatable medical condition. MOUD is the standard of care for the treatment of OUD. Involuntary withdrawal of MOUD and or involuntary abstinence in a controlled environment results in an increased risk of death upon release or potentially within the incarcerated setting. So drug and alcohol intoxication deaths in custody more than quadrupled between the year 2000 to 2018, from 37 to 178 deaths per 100,000 individuals in custody. Suicide remained the leading cause of death in local jails in 2018, accounting for almost 30% of jail deaths. And from 2000 to 2018, individuals in custody who died of drug or alcohol intoxication had served a median of 1 day in jail prior to death. Who supports MOUD in correctional settings? So first, from the National Sheriff's Association, jails can minimize the risk excuse me, of post-release overdose by facilitating continued access to MOUD for individuals who are on prescribed FDA-approved MOUD, and by facilitating initiation of MOUD for individuals with OUD who were not receiving MOUD prior to arrest. From the American Correctional Association, we support the use of evidence-based practices for the treatment of opioid use disorders. And from the National Commission on Correctional Healthcare, we see OUD as a chronic illness and that correctional facilities have an important role in providing access to continuing and initiating treatment, just as they do for people with diabetes or other chronic illnesses. So a little bit more from the National Commission on Correctional Healthcare. This comes from their governance board from March 11th of 2021. So what are the options for providing MOUD in correctional facilities? One is transporting incarcerated individuals to community opioid treatment programs or to a hospital, as is sometimes done during pregnancy for incarcerated individuals, for medication dosing. OTPs may have the option of requesting waivers for use of takeout doses in order to minimize the number of transports. And as we know right now, extended take-home doses are allowed per SAMHSA and the DEA, so up to 14 take-home doses for less stable patients and up to 28 take-home doses for more stable patients with methadone. You can partner with community OTPs for dosing of incarcerated individuals within the facility. In this case, the dosing is done under the license of the community OTP. Have correctional providers obtain buprenorphine X waivers. As I mentioned, if the intention is to prescribe to fewer than 30 individuals at one time, then you don't even need to do the formal education component. So a waiver permits use of buprenorphine for the treatment of OUD as well as for the use of it for treating withdrawal symptoms. Obtain an OTP license for the facility itself. This permits use of methadone and buprenorphine for both treatment and withdrawal. And the National Commission on Correctional Healthcare does accredit facilities for being an OTP. Obtain state and DEA licensing as a healthcare facility. This entitles the facility to the same exemptions as hospitals for adjunctive use of methadone or buprenorphine in management of pregnancy or other conditions, for example, for HIV or for mental health diagnoses, et cetera. So how do we define success when we're looking at MOUD in the correctional setting? So it's definitely a partnership between multiple entities. So what could that look like? So providing MOUD and quality medical treatment during incarceration, ensuring successful reentry with warm handoffs and continuity of care and recovery support services after release, reducing recidivism rates, decreasing overdoses and reducing hospitalizations post-incarceration, decreasing viral infections for people in the justice system, such as HIV and hepatitis C, and increasing connections to care and services. And who could that be a partnership between? Community corrections and reentry, the public health and healthcare system, correction facilities, public safety, Medicaid and managed care organizations, and behavioral health organizations and partners. So what is the data from the MOUD experience in correctional settings? So first, the Albany County Jail experience. Recidivism rates for MOUD program participants from the Albany County Jail. So 91% have not returned to jail, 4% have returned to jail for a previous charge, and just 5% have returned to jail for a new charge. The evaluation of the program showed that there were 0 overdose deaths of any MOUD program participant post-release from jail. What about the Rhode Island experience? So Rhode Island decided to do statewide provision of MOUD in incarcerated settings in Rhode Island since 2016. This has been implemented by the Rhode Island Department of Corrections. It was the first state in the United States to do so. All inmates are screened for OUD, and MOUD is offered to all inmates who need it. Their evaluation 1 year after implementation statewide was a 61% decrease in post-incarceration deaths, and overall, a 12% reduction in overdose deaths in the state's general population. So, what is the legal precedent for MOUD in correctional settings, and what is some of the litigation and legislation in New York State pertaining to MOUD in correctional settings? So first, what is the legal precedent for MOUD in correctional settings? So I'm just going to look at a few cases here. This is not an exhaustive look. So the first case was Pesci versus Coppinger, and this was in the federal court in the District of Massachusetts in 2018. A person with OUD who was stable on methadone treatment at an OTP for 2 years and in recovery faced a 60-day jail sentence and was told that MOUD was not available to inmates. He sued, and the ACLU argued that the jail's no methadone policy violated the Eighth Amendment and the ADA and won the case. The jail was ordered by the court to provide MOUD, specifically methadone, during the plaintiff's incarceration. Next case, Smith versus Aroostook County, and this was Federal Court District of Maine First Circuit in 2019. A person with OUD, stable on buprenorphine treatment, faced a 40-day sentence and was told MOUD was not available to inmates. She sued, arguing that the policy violated her rights under the ADA. The jail was ordered by the court to provide MOUD for the plaintiff. The lower court's decision was affirmed by the First Circuit Court of Appeals, finding that the defendant was likely to succeed on her ADA discrimination claim. Court Lever versus Whatcom County, Federal Court, District of Washington in 2018. This was a class action lawsuit that sought MOUD for all current and future incarcerated persons with OUD where appropriate. So this went beyond the individual plaintiff. The case settled when the Whatcom County Jail agreed to and then created and implemented written policies for MOUD, mainly buprenorphine maintenance and induction and medically assisted withdrawal, as well as guidance for training and implementation. The new policies applied to all non-pregnant people. Pregnant people already could receive MOUD in the Whatcom County Jail before this particular case. So for all non-pregnant people who have an OUD and are incarcerated or will be incarcerated in the future at Whatcom County Jail. So given emerging case laws, how have states where these cases have occurred responded? So first, let's look at Massachusetts. In Massachusetts, the Department of Corrections began offering naltrexone in 2014. In 2019, the state passed legislation requiring the provision of MOUD at the Massachusetts Alcohol and Substance Abuse, they have not changed that name, Center in Plymouth, a unique state facility for both incarcerated individuals and people under civil commitment, as well as in 3 of the state's correctional centers. And the state has since begun offering all 3 FDA-approved forms of MOUD to incarcerated individuals. What did Maine do? Maine's Department of Corrections began an MOUD pilot program in early 2019, which has since expanded statewide. In collaboration with all 15 of the state's county jails, the Department of Corrections created a model jail based on MOUD policy, and all 15 county facilities provide MOUD, so naltrexone and/or buprenorphine, and in some cases, methadone to eligible individuals. What did Washington State do? Washington passed legislation in 2019 requiring city and county jails to provide MOUD to individuals who had been receiving treatment in the community prior to incarceration and to individuals 30 days prior to release as appropriate, subject to securing funding. The legislation also required city and county jails to make reasonable efforts to connect individuals with community-based treatment upon release. And as of October 2020, at least 5 other county jails were providing MOUD to eligible individuals who were incarcerated. So what is happening in New York State? So what's some of the history in New York State? So Rikers Island has been providing MOUD to incarcerated individuals since 1987. Individuals receive a clinical assessment at the point of intake that included a urine drug screen and screening questions to determine eligibility to participate in their program. The state has used federal funding through SOAR grants and other state funds to support increased access to MOUD in jails and prisons across the state. So many counties in New York offer some form of MOUD in their jails. Some of them are listed there. And in early on in the State Department of Corrections, so this would be state prisons, about 10 of the state's 50 prisons offered MOUD as of September of 2021. And other thing that's notable is in February of 2021, New York was awarded $32 million as part of the opioid settlement agreement. And more than 20 million of that total amount received went into the state's general fund, while the 11 million was set aside to pay for MOUD in state correction facilities. So what happened litigation-wise in New York State? So what has been the precedent here? In 2014, the U.S. District Court for the Southern District of New York refused to dismiss a case alleging constitutional claims against Westchester County. So the provider of on-site medical services was denying individuals MOUD. So what are the details? The suit alleged that 3 incarcerated individuals were uniformly denied methadone and buprenorphine naloxone, so a dual formulation of buprenorphine, for 9 months, despite alternate treatment not being effective and a county policy in place to provide methadone or buprenorphine-based detoxification. The court found that the plaintiff's allegations regarding the defendant's deliberate indifference to his medical needs were plausible enough to sustain his claim. The case was later dismissed in 2015 due to the plaintiff's failure to take any steps to prosecute their action. In April of 2021, the New York Civil Liberties Union and the ACLU's National Prison Project represented a plaintiff in a lawsuit against Jefferson County over its policy of denying MOUD to people with OUD in the Jefferson County Jail. The plaintiff was facing potential detention at the Jefferson County Jail, and the suit alleged that the facility's policy of prohibiting MOUD violated due process protections under the 14th Amendment and discriminated against people with OUD in violation of the EDA and the state anti-discrimination laws. So what happened in this case? So the title of this case was PG versus Jefferson County, and this was, again, heard in the federal court, Northern District of New York, in 2021. So on September 7th of 2021, the judge ordered that the plaintiff's motion for a preliminary injunction be granted, and defendant shall provide plaintiff with his daily prescribed methadone during his period of incarceration at the Jefferson County Jail in a way deemed appropriate in light of security needs, such as providing the medication to the plaintiff in the jail, taking the plaintiff into the community on a daily basis to receive their medication, or releasing the plaintiff on medical furlough if the jail is unable to accommodate his daily medical needs. So very clearly made the point that the patient needs to receive his medication. So in addition to that, legislation was happening in New York State. So in 2021, both houses of the New York State legislature passed legislation which required the New York State Department of Corrections to establish an MOUD program at state and county correctional facilities. The program was required to offer at least one formulation of all FDA-approved medications for SUD, including MOUD. So my read of the legislation is it goes beyond opioid use disorder, as we have FDA-approved medications as well for alcohol use disorder and tobacco use disorder, as well as providing withdrawal management, group and individual counseling, clinical and peer support, discharge planning, and reentry and transitional support to any incarcerated individual determined to have SUD. Jails without the resources necessary to meet the Act standards or without a nearby accredited MOUD provider may apply to the Commissioner for limited exceptions. On October 7th of 2021, Governor Hochul signed that bill into law, and New York State jails and prisons have 1 year or until October 2022 to implement the legislation. So let's go over some conclusions for treating opioid use disorder in correctional settings with MOUD. So MOUD is the standard of care for the treatment of opioid use disorder. There is clear evidence for the benefit of opioid use disorder in persons with opioid use disorder. Incarcerated persons with opioid use disorder are entitled to the same standard of care for the treatment of opioid use disorder as non-incarcerated persons. This is increasingly clear as evidenced by legal precedent and legislative actions by states. The benefits of MOUD for incarcerated persons are clear, particularly decreased overdose mortality and all-cause mortality rates post-release and decreased recidivism rates for reincarceration. The benefits of MOUD for incarcerated patients are clear with respect to correctional staff as well. A calmer environment in the jail or prison, fewer behavioral incidents among inmates, decreased contraband entering the jail or prison, and decreased overdose deaths among inmates. And in New York State, both legal precedent, the case we just went over in Jefferson County, recent legislation, and the governor signing that bill into law indicate that the expectation in New York State is that persons with OUD are treated with MOUD in the correctional setting. So very briefly, let's go over some psychosocial and treatment strategies for engaging and maintaining individuals on MOUD. So the first strategy is person-centered care and person-centered discussions involving the individual about medication for addiction treatment. So what does that look like? They should be professional discussions, courteous, non-judgmental, and respectful. And it is a discussion of medication for addiction treatment as part of treatment and ongoing recovery. Sharing accurate information about medication for addiction treatment options. So knowing key details about different medication for addiction treatment options for alcohol use disorder and opioid use disorder. Understanding why a medication may be prescribed or dispensed to a specific patient, and displaying patience and permitting sufficient time for questions to be asked. I would also say this is not a one and done conversation. Many patients may have internalized stigma around the use of medication as part of recovery, which they may have heard from family or friends or from self-help groups or from their PO, etc. So it's important to dispel the myths that they may have internalized and to talk about the distinct benefits of these medications in enhancing recovery. So it may take a while and multiple conversations for that information to sink in for that individual in front of you. So it also involves shared decision-making in these discussions. So presenting medication for addiction treatment as a treatment possibility, discussing all the options. Often use of a visual aid is helpful, so letting patients know what the medications look like, etc. Each option of medication for addiction treatment has advantages and disadvantages that are patient-specific and patient-driven. So it's important to know what is important to that individual. And again, providing accurate information about all options, not giving a prescribed recommendation that's based on your personal beliefs. Asking the patient to rate their options, providing a safe space for them to do so, and providing more detailed medication for addiction treatment information and/or directing patients to fact-based information, sometimes with the medical personnel, if it gets beyond your knowledge base. providing informed consent so that the person clearly understands the risks and benefits of the medication, and ultimately recognizing that it's the patient's decision, not the treating provider's decision, but making sure that that decision is not based in a vacuum, but that is based on accurate information. So it's important to dispel the misinformation about medication for addiction treatment, some of the things that I already went through in this talk. So medication for addiction treatment is an evidence-based treatment. Medication for addiction treatment is not substituting one drug for another. Medication for addiction treatment may be short-term for some patients, though there's much better evidence for long-term or lifelong treatment intervention with medication for addiction treatment. And those on medication for addiction treatment are in recovery. So it's important to listen to patients about their own personal experiences that they may have had with medication previously. So maybe they were not treated to an appropriate dose that it actually stopped their withdrawal symptoms, or maybe they had continued cravings because, again, they were not treated to an appropriate dose that helped with their cravings. Did they have particular side effects? Perhaps they had too much sedation because they were over-medicated on their methadone dose, for instance. Or perhaps they weren't instructed correctly on how to take buprenorphine and they took it too early and experienced precipitated withdrawal. So now they are associating buprenorphine with withdrawal rather than understanding the benefits it can have for them. Do they have other questions or concerns? Again, if it goes beyond your own personal knowledge base, refer them to medical personnel who may be able to answer their questions better. There are multiple resources that were used for this presentation, and some of which are listed here. And if there are any questions, you can either email me directly at OASAS, and my email is on the slide, or you can email the Learning Thursday mailbox. And thank you very much for your attention to this presentation.
I want to thank our presenter for today's program. I hope you all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we're meeting your educational goals and expectations. Once you've viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation, including suggesting any future topics for Learning Thursdays. Once again, thank you for joining us and keep up the good work.